It's so great to be here. So some of you know me, and was anyone in the cadaver lab with me yesterday? Okay, great. So we'll do a little formal lecture and talk about this. We don't have much time, so my goal with this lecture is just to keep the key points, drive them home, and hopefully make you see, as I would say to our residents, the light of non-depolarizing agents. So let's start. I really think that slide looks to me like succinycholine, and I say this from the heart. I grew up with Sucks. It was like a blue blazer that I used on interviews. It never failed me. But Sucks came out of the OR in the 50s, and I'll show you how that came out, and we can do so much better than that. But I'll show you why it isn't the best paralytic to use, even if you're going to talk to me about status, head trauma, or so forth. So let's go. These are my 4 things. Number 1, we no longer sniff people. I'll show you that you really need to ramp somebody up. If you don't know what that means, please, I'll show you some lateral pictures. If you take one pearl from that, number 1 is to take the ear to the sternal notch on a lateral view when you look at somebody. Everybody should get that, not just an obese patient. I'll show you why. Succinycholine, sucks, and I will say that word as S-U-X on the way in. Why is that? I'll show you that depolarizing agents utilize oxygen. You pay for oxygen to use sucks. At the myoneural junction, it chews up oxygen. It is not your friend to get depolarization of it. Non-depolarizing agents don't do that. On the way out, if you thought, and I say this so with you, that sucks has this magic 8 minutes duration, and if you failed the airway, your patient will wake up, shake your hand with a pulse ox of 99%, you're clearly misled. It's a very bad place to be. I've been there multiple times in my career, and I'll show you why it's so bad. And the last thing we have to talk about now, if you look at the standard, I think in good airway management, is we're all no desatting these people. If you don't know what that means, we're going to use a nasal cannula, and I'll show you why it's your friend. So let's go. Throughout this whole slide, it's never about the tube. It's about oxygen delivery. You know this. If you're seasoned in emergency medicine and have intubated as much as I have, it's all about hypoxia. It's not about your tube. It is about your view. Your tube delivery is independent of your epiglottic view, but it's maintaining sats, regardless if this is an obtunded alcoholic versus somebody who's in severe hypoxia from a respiratory issue. So it isn't about the tube. It is about keeping their sats high. This graph is 10 times older than I am, but it showed you when Benemoff did this in anesthesiology that the plateau of crashing of someone who is severely sick or obese, you have no time on your side, meaning that they are like Pac-Man and they chew up O2. So the bottom line of this entry of this lecture is that how can you maintain the sat high on somebody who has the potential to be a difficult airway or is going to utilize oxygen severely, right? You and I would be all the way to the right of that. We can maintain our O2 sats if we're healthy, normal O2 delivery, normal lungs, normal CNS, but that's not who you see in the ER. And if you practice inner city medicine like I do, our patients become more and more obese and they're difficult to use. CO2 is also not your friend. Remember, here's the bottom line. What's the bottom line of hypercarbia? It is this. Your cardiac conduction is pH dependent. You would say if you did pulmonary critical care that we can be permissive hypercapnia. That's very true on a vent when you're delivering O2. When you're doing pre-RSI and you're severely hypercapnic and your CO2 is 70, 80, 90, going up and that's severe asthmatic, you're going to get bradycardia and cardiac arrest. So this is not your friend either. All I want you to know from this slide, this is a great study that was done. The more attempts you do, the higher risk of death, cardiac arrest. No matter how good you are. Why is that? Hypoxia, hypercarbia. Don't just lay there, sit them up. I'll show you that I don't think you should intubate anybody flat on a bed, even if they're built like you or myself. Especially if we look at, we'll use TBI, traumatic brain injury, as an example. What are the benefits of sitting somebody up? Number 1, if you elevate the head of the bed, what are you doing? You decrease the risk of hypoxia. How do you do that? You recruit collapsed alveoli. Each one of you have collapsed alveoli if I lay you down. Not obese, not gravid in 3rd trimester, not trauma. You increase that functional residual capacity, that bank of O2 that I'm going to rely on when I make you chemically apneic from induction agent and paralytic, right? You want to open up or decrease VQ mismatching, and that's what you're doing. So you have better bank of O2 to rely on. Nice to know. And also, if you're doing head trauma, if you elevate somebody's head a bit, another pearl is you lower ICP. So anybody who has a head injury, you're alcoholic that may be found down that you don't know, elevating the head of the bed gives you a nice bang for the buck, even out of the lung box. That's how you do it. So if you say, well, Dr. Butler, I can't do this, they're boarded and colored. Oh, yes, you can. You just throw them in reverse Trendelenburg. Everybody's happy. The lungs are happy, the brain's happy, and your pulse oximeter's happy. Nice to have that. Okay, let's get back to this. So if you have a no-carb left-behind patient, such as the bottom of this picture, you look at them laterally. EMS is on the radio. EMS is wonderful. They have 10 times worse of a job than I ever will have. They're the Bob Vilas of EMS, right? They do absolutely everything with nothing. But if they tell you on the radio they have a morbidly obese patient, I think that's PC to say on the radio. You get ready and you get your bed in this position because the money is transferring that patient from their stretcher to yours. So you need that preparation, have this ramped up. You visually see these patients in your mind. If you take the ear to the sternal notch, what do? These are MRIs. These are wonderful pictures. Rich Levitan, myself, other people were involved in these studies. We look at them when they lay flat to when we elevate their head or do them in ear sternal notch. You open up their access and they breathe better. If all of you were in severe respiratory distress and you were standing, you would lean forward and align your airway axis in the same lateral ear to sternal notch. Opens up that pathway, lets air get in. This is laying back. This is them sitting up. And you're going to get more oxygen delivery. So now you're going to say, well, Dr. Butler, the patient isn't breathing. How can we get them more oxygen delivery? Well, we can with a nasal cannula, and I'll show you how to do that. So let's get to the money of this lecture very quickly and easily. I'm going to make it as clean as I can. Sucks costs you oxygen. How does it do that? Depolarizing agents, myoneural junction, chew up oxygen to make you paralyzed. If you learn one piece of pharmacology and physiology, that's it. This just came out in the literature not that long ago. We all love sucks. We compare it to this magic go down in 1 minute. We're all inpatients, physicians. I clearly am. I may not have a full minute. So you're going to say, well, I never want to touch a non-depolarizing agent because it takes too long. Well, that's really not true. When the studies came out that looked at rock versus sucks, if you front load, give enough depolarizing agent, we're going to use rocuronium as a depolarizing agent, and give at least 1 mil per kilo, you will go down in that magic 1 minute that you all grew up with on sucks. So we're equal right now. We think, and please understand I underline belief, that the patient, if you missed, will wake up in this magic 8 minutes, nice and short duration, have a O2 that's really high, shake your hand, and have a pulse ox of 95%. I've been there, it's horrible, and it never, one more time, it never happens like that, regardless, even if they're just obtunded from drug or alcohol. Anesthesia 2010, we looked at this, and they are clear. These are the anesthesiologists who love succinycholine. They probably have a succinycholine poster hanging behind that drape when they're intubating. I'm sure they do, right? The onset of O2 desaturation during apnea is increased with sucks. Sucks is not your friend. It costs you oxygen. I love saying that because it does. Desaturation is higher when these people come out of it. On the way in, chews up O2, myoneural junction. On the way out, it also chews up oxygen to get the patient back to normal muscular contraction. So it sucks in and it sucks out. Depolarizing agents. You're in a lose-lose box, especially if your patient is hypoxic. Scandinavians looked at this. I don't know how these patients were overweight in Scandinavia, but they looked at morbidly obese patients and they chewed up oxygen. Remember? They just, right? For so many reasons. Their functional residual capacity is nil. They have no bank of O2 to hold on. Their metabolic rate is higher, similar to a pediatric patient, and their pulmonary structures don't dictate good ventilation, any way that you can look at it. So we can do clearly better than Sucks, right? Rocuronium and non-depolarizing agents are much better. And without opening up this whole can of worms, you will say, well, Dr. Butler, the risk of hyperkalemia is low. I don't argue that. But I'll tell you this, I think I'm well read on this. If you go back to the literature on Sucks and hyperkalemia to say it only has a marginal bump, 99% of those papers, the patients were not sick. They were hyperkalemic at baseline, but they were not sick, meaning they weren't profoundly metabolic, acidic, and shifted K. So I'd be leery about that, but I'll even let that pass on this. So this is the second half of this, of why don't you want to use Sucks. You'll say, well, it lasts longer. It lasts 30 minutes. I don't have 30 minutes. It's not good. But you do have 30 minutes. You make intubation easy. It is this: awake or paralyzed. If you made that decision to paralyze your patient, I would want them paralyzed my whole shift. Why would I want them to wake up? I don't get that, right? I don't want to hear the hum of that vent irritating me with those bells and whistles. I'm not good at that. I hate that, right? So if you made that decision to paralyze, I want to sign them out paralyzed. So let's finish this up. Is it a bad thing? Well, I have been there, so I say this from the heart. I think good lecturers bring their errors to a lecture, and I certainly have been there. You, if you will, in this example, gave your patient Sucks because you don't like non-depolarizing agents. They last too long. You failed your intubation. For whatever reason, I'm going to take the lungs out of the physiology. You failed. I, at the bottom, the same patient, I failed. You're going to say to me, well, now we need to redose succinycholine. If you find a paper that shows me the exact dose of the second dose of Sucks, and should you give atropine because it may cause bradycardia, I'd like to see that. It's not in pharmacology or in anesthesia's literature. Your patient now is waking up, bucking, biting, and changing their vital signs. My patient is doing what? Absolutely nothing. Who has a better chance of reintubation? You clearly do on somebody who's completely paralyzed. If you don't buy that, you'll have to buy this. If you say, okay, I want to use a rescue, I'm into LMAs. Patients clearly in the data that had LMAs that were sedated and paralyzed had a better chance of ventilation and a decreased risk of aspiration. So I win, for lack of a better word, on someone who's completely paralyzed. If you go out of the United States, most countries that Mike introduced me with have Sugammadex, which is the Narcan of non-depolarizing agents. If you don't know what that is, it will completely reverse a full dose of rocuronium in 2 minutes, meaning that your succinycholine lasts longer than my drug. So we've lost it. Sucks, 1952. This was the cover of Life magazine in 1952. I think that's hanging in the OR. Sucks was born in the OR. Personally, that's where I think it should stay. Why is that? Anesthesia and emergency medicine are apples and oranges. I have great respect for them. Why is that? They want to cancel that case. You've all seen that on anesthesia's algorithm. Why not? Let's use Sucks. This is a healthy 35-year-old woman with an elective gallbladder removal. Absolutely. Why not use this? You and I don't have the options of canceling cases. Why use a drug that's always going to hurt you? Doesn't make any sense. Okay, I said Sucks costs you oxygen. How do you replace that when you stop the patient from breathing? If you're not doing no desat, you need to. If this is a new concept, I'll make it as clean and easy as I can for you. The pneumatic means nasal oxygen during efforts in securing a tube. Please look carefully at the picture because I will say this to you, even some of our respiratory techs here at university, when I'm doing this and the patient was being on a non-rebreather, I had this under the non-rebreather. They'll take their scissors quickly out of their pockets and cut the nasal cannula. So you need to be very clear that you tell respiratory this is to stay on and educate them if they don't know. So what's happening? Here's the bottom line. If I make you apneic, your gas diffusions are different between O2 and CO2. You're chewing up O2 even though you're chemically apneic, but your diffusion of CO2 isn't that high. So what does that mean? It means that there's a gradient in your lungs. Your nasal cannula will help you absorb this O2. Your heart is beating. There's vasculature, great vasculature in the head and neck, and you will actually hold on to O2 and utilize it. Anesthesia studies even got oxygen levels higher with nasal cannula. So O2 will flow from the pharynx, the nasal pharynx, to the lungs. And just to step away from this for 1 second, if you're doing traumatic brain injury patients, the literature is scant on hypothermia and head trauma, but we know it lowers ICP. What hurt the data was its rate of rewarming. Where am I going with this? Nasal cannula, no DSAT, actually minimally, very minimally cools the brain. Nice way to start that and make neurosurgery happy. So I think that's great bang for the buck. Okay, O2 will go down the trachea. I love it. Oxygen is always needs to be maintained. We said that when we introduced ourselves, right? O2 gets drawn in without going into gas absorption and gas utilization. All I want you to know is there's a gradient at the lungs. CO2's diffusion is not as high as O2. The lungs become subatmospheric and O2 goes down into the lungs. This is what's happening when you push your paralytic and your induction agent together. You put the patient on nasal cannula, look at the gradient between O2 and CO2, much higher, O2 will go in and the patient will breathe better. Excuse me, the patient's SATs will maintain at a higher level. This is even in patients that have severe respiratory distress, CHF, fluid. There are still alveoli that will exchange gases. Nice to have that. Hopefully, you're still sitting the patient up as we talked about. Okay, there's my picture. So, look on the left. I personally never bag a patient unless we have to. If you're doing RSI and pre-oxygenated, you put them on 100% non-rebreather. Underneath the non-rebreather, if you look carefully, is the nasal cannula. The cannula stays on when you make the patient chemically apneic. It doesn't obstruct your view whatsoever. The future of this may even be vapotherm, maybe down the road for this. We'll see where this goes. There are also little nasal BiPAP and CPAP units. You've seen them in pediatrics. I honestly think that's going to be the wave of the future. You could leave that on, you could BiPAP or CPAP, and it would not obstruct your view. So nice to know that that's probably on the horizon of what's going to happen. Okay, I'm just about done, even though I speak fastly. 1, every patient you should sit up, regardless of why. Just think about that. Your functional residual capacity in all of you, healthy lungs, healthy brain, is collapsed or diminished if I lay you flat. Put that with third trimester, morbid obesity, and God knows what else, or a full stomach, doesn't make much sense. You're not going to recruit those alveoli unless you sit them up. You'll decrease VQ mismatching, and if you're doing a head, you'll help drain with venous return. Nice bang for the buck. Succinycholine, grew up with it, I loved it. Doesn't make any sense. And for you, and I have to say this, not to be funny, for the people that are diehard sucks, after your sucks wears off and you've intubated that patient, what do? You give them VEC, don't you? I know you do, even though you won't raise your hand, but I know you do. So for you in the back of the room, so why not start with a non-depolarizing agent? Right? Doesn't make any sense to do that. Pulmonary critical care would say, and I quote them, my colleagues, you must let the vent work for you. If your patient's waking up and bucking or biting the tube and you need to re-paralyze them, you've lost that window of stable vital signs. Doesn't make any sense to do that. I personally don't think it does. Just rock them. And if you're in an institution that doesn't have rocuronium, I feel your pain. Yep. Are we good with time? Okay. If you don't have rock, you can give them double dose or triple dose VEC will work the same and give them a nasal cannula for no DSAT. Thank you so much.